All right, I think this is just about time, so we will get started now. Welcome to everybody. Thanks so much to everybody who has joined us today for our webinar. My name is Emily Clark. I'm a knowledge broker at the National Collaborating Center for Methods and Tools. Our webinar today is on equity and knowledge translation with insights from the 2021 Knowledge Translation Student Award recipients. I'm very excited to introduce our panelists as we get closer to that part of the presentation. For now, just a few housekeeping items before we start this webinar. In terms of internet connection, if you're able, we do recommend using a wired internet connection for the webinar. If possible, using the latest version of Google Chrome or Firefox will work best. If you do have any technical difficulties, please feel free to send a private message to Alana Miller at the NCCMT. You should see her in here as a panelist. She will be able to take care of any technical difficulty requests that you may have. If you have any questions for the presenters throughout the webinar, please add them to the Q&A section. We'll make sure that we get to those at the end of the webinar. We will have just a few polling questions today during the webinar. They help us get a sense of the audience that's with us today. When they're open, they'll pop up over the slide. There may be a slight delay between us opening it and you actually seeing it on your screen. But once you enter your response, please make sure that you hit submit. After today's webinar, we will post the recording in English as well as the slides in both English and French. You can access those on our YouTube and on our SlideShare accounts. We'll make sure that we tweet when those are posted, so you can keep an eye on our Twitter account at NCCMT. Here's our first polling question for today. We're interested in knowing how many people are actually joining us today. This was a lot more relevant in the days before COVID when we'd have people in offices joining together. We do know that some people have started returning to the office, so we're making sure that we capture this here. So make sure that you answer each of the questions and then hit submit. We're also interested in knowing whether or not you're familiar with the National Collaborating Center for Methods and Tools, if you've used any of our resources before, and if yes, how many times you have used those resources. Again, just to get a sense of our audience and whether or not you are familiar with what the NCCMT has to offer. I see the responses are coming in. Looks like most people are joining solo still. I know we're talking about, we're hosted at McMaster, we're talking about returning in January now. And it looks like we've got a pretty even split between people who are familiar and are not familiar with the NCCMT. So really great to see some familiar and some new faces. And I will go ahead. I think we've got almost all the responses. I will end that and move on. The National Collaborating Center for Methods and Tools is actually one of 6 national collaborating centers across the country. We're hosted at McMaster University in Hamilton, Ontario, which is located within the traditional territories of the Mississauga and Haudenosaunee Nations, within the lands protected by the Dish with One Spoon Wampum Agreement. Our goal is to support public health professionals and organizations to integrate evidence-informed decision-making into their work. The National Collaborating Centers are funded by the Public Health Agency of Canada, and we each focus on a different topic area in public health, a priority topic area. So from the West, we have the NCC for Indigenous Health in Prince George, British Columbia, the NCC for Infectious Disease in Winnipeg, Manitoba, the NCC for Environmental Health in Vancouver, the NCC for Healthy Public Policy in Montreal, and the NCC for Determinants of Health in Antigonish, Nova Scotia. So while these NCCs focus on more of the specific priority topic areas, here at Methods and Tools, our main focus is on evidence-informed decision-making with tools and resources that can be applied to all topic areas in public health. We do have many products and services that can support public health professionals to do evidence-informed decision-making. This includes a registry of methods and tools. We've got over 270 methods and tools in that registry. We have online learning opportunities, which include 12 different online learning modules, hopefully some new ones coming soon. We do conduct workshops, which now have been primarily virtual. Public Health Plus is a repository of public health research. We have a number of video series, including our popular Understanding Research Evidence videos. Those go through different concepts that you would encounter in research, like statistical terms, in short and easy to understand videos. We also engage in quite a bit of networking and outreach across the country as well. So enough about us. We are very excited to present the winners of the Knowledge Translation Student Awards for the year 2021. These awards are presented by the National Collaborating Centers for Public Health, all 6 centers as a whole, and are awarded to outstanding graduate student projects in knowledge translation that are relevant to public health. We're very excited to be joined today by Erica Phipps, who at the time of her project was attending Queen's University, Sujane Kandasamy, who was at McMaster University, as well as Lee McClarty at the University of Manitoba. I will allow each of our panelists to introduce themselves. I know some of them have since graduated since submitting their applications. And with that, I will hand it over to our first presenter, who will be Erica Phipps. I believe Dr. Phipps now. So I've stopped sharing my screen. Yeah, and you can go ahead and share yours.
All right, are you seeing it?
Yep, that looks great.
Great. So thank you, Emily. It's a pleasure to be here. My name is Erica Phipps, and yes, I did complete my doctorate. I'm now a postdoctoral fellow at the University of Ottawa and continuing my role as executive director of the Canadian Partnership for Children's Health and Environment and the KPSC-led project Rent Safe. So today I'm going to share with you some of the learnings and approaches we explored through my doctoral research, the Rent Safe EQUIP research project for housing and health equity. EQUIP stands for Equity Focused Intersectoral Practice. We undertook the research in the community of Owen Sound, Ontario. For those of you who don't know Owen Sound, it's a small city of about 22,000 people in a largely rural area, proximate to 2 First Nations reserves on the traditional territories of the Anishinaabe and Ojibwe people. So our goal through the research was to catalyze and support interaction from people from diverse sectors in the midst of this escalating housing crisis. First off, to better understand the causes and the consequences of housing inadequacy, namely health inequity and social injustice, and to foster new ways of thinking about not just the issues, but also about solutions. So a bit of a backdrop on the research. So we implemented it as community-based participatory action research. We were fortunate to have a multi-year grant from CIHR. And foundations for the work came from the Rent Safe initiative, which I was leading in my role with KPSC, the Canadian Partnership for Children's Health and Environment, in which we were really trying to get a sense of the intersectoral capacity to respond to the health inequities experienced by tenants living on low income. So through focus groups with tenants in various communities across the province of Ontario and sectoral surveys with professionals, public health practitioners, legal aid clinic staff, bylaw officers, et cetera, we came to see this picture of disconnected systems, which was stymieing the ability of tenants to seek out and obtain remediation for unfit housing conditions such as mold, lead, pest infestations, lack of heat, et cetera. As well, the work was grounded on some of the work that I had gotten involved with Dr. Jeff Masuda and others on equity-focused knowledge translation, which is essentially an approach to thinking about knowledge practices that questions the very nature of knowledge utilized and whose voices are heard and included in public health practice or other intersectoral work. So we traditionally start with scientific data and try to move that knowledge into the community level. Some of this equity focused work challenges those habits that we have in our knowledge translation work. So overall, the goal of the research was to do two things. One was to see what happens when you invest in human relationships, and what happens when you provoke critical reflexivity among professionals working in intersectoral practice, with the hope that we could help to better understand and perhaps start to deconstruct and transform the knowledge practice among intersectoral actors. And I've included some of the papers that explain some of that backdrop, including one that we did together with the National Collaborating Center for Determinants of Health, if you'd like more on that. So the key way that we approached this work was to center grounded expertise. And I use that term grounded expertise. People generally use the term lived experts, people with lived experience, because the term expertise really reflects that knowledge that people who are directly experiencing social injustices and health inequities can bring to this work. So I was really privileged to work alongside first 3 and then later 4 tenants living on low income in Owen Sound, who were my co-researchers and who brought to the work their expertise and experience as tenants in the midst of a housing crisis, as well as experience of indigeneity, gender-based discrimination, trauma, mental health concerns, and other life challenges. So the work essentially rolled out in 2 phases. The first phase was a series of 11 what we call learning exchanges, somewhat like a focus group, but the real difference here is that instead of being convened by professional practitioners, the conveners in this case were the tenants with low incomes who were living in the housing inadequacy that we were working to address. So we co-convened these learning exchanges, brought in usually a handful of people who were sort of randomly selected based on availability. So in any given session, you may have a landlord, you may have somebody doing frontline mental health services, you may have somebody from the social housing department or public health. And what was really remarkable in these sessions is that people almost immediately started to relate as human beings and start to look for ways of commonly understanding and sort of co-creating that understanding of the crisis that the community is experiencing in terms of housing, not enough housing, deteriorating housing stock, all sorts of intersecting challenges. So throughout those learning exchanges, we started to see people questioning their own habits of thought, their own practices, and all of that was catalyzed by the fact that it was tenants with lived experience who were actually posing the question and bringing those conversations to bear. The second phase of the research was an experiment. We convened a 4-day intersectoral retreat at a rustic lodge far from Owen Sound. We invited all the learning exchange participants, and we were very fortunate to have 30 people, including community members and the research team, spending this immersive time together. And the key focus here being investing in human relationships across those traditional divides of social class, of professional role, of landlord, tenant, service provider, service recipient, etc. Some of the key features of the design of this intersectoral retreat experiment was that we purposely sought to center Indigenous ways of knowing and experiences of home and housing inadequacy. The entire event was facilitated by a local Indigenous knowledge keeper and a facilitator that we brought in from the outside. It also turns out that we almost immediately got a sense of togetherness and solidarity because of the major snowstorm that descended as we arrived. We arrived to find that the lodge had no heat. And it was remarkable, and participants commented on it later, how quickly roles ceased to matter. Everybody just pitched in and gathered the blankets and made a fire and so forth. We eventually did get our heat back, but it was a really potent learning in the context of talking about housing, and also very quickly catalyzed people interacting as community members and neighbors as opposed to traditional roles. Other features of the retreat, we purposely tried to move people out of their comfort zones. So we had a practitioner of theater of the oppressed lead us in a number of exercises, as you can see there. And we built in a lot of downtime, a lot of unstructured time for informal relationship building and interaction. It turns out that tobogganing is actually a very effective intersectoral capacity building tool, and lots of fun too. So what did we hear? So obviously, and certainly, we heard a lot about the housing crisis. We heard about, the fact that tenants are spending, in core housing need, more than half of the tenants spending more than 30% of their income, not enough capacity, not appropriate for the needs of people seeking housing, and of course, the condition of the housing not supporting wellness, but quite the opposite, contributing to those health inequities. We definitely heard that people on the outside, the tenants seeking supports from the system, feeling excluded, feeling that stigma, feeling that almost a fear to speak up for fear of losing their housing or triggering some other consequences, such as having their children taken away, etc. But equally, the people on the inside, the professionals, feeling trapped in a siloed and rigid system, not being able to successfully respond to the urgent needs that they're seeing right in front of them, and feeling trapped inside that system. And also, of course, it was really rewarding to see that people were really starting to reflect on the intersectoral collaboration that happens in the community, and appreciate it for its value and the power it brings to addressing some of these chronic systemic challenges. So as people moved through the process and coming out of the retreat, they were saying things like, it's not just okay, it's actually imperative to prioritize relationships. So seeing investment in human relationship building is actually a productive use of time, and the need to start thinking of relationships as a resource. We put a lot of emphasis on knowledge mobilization and building that community momentum with the principles of participatory research, of course, is not extractive. You're trying to contribute to local capacity and sustained action. We did a report to the community called We Are All Neighbors, and presented the research at a high-level intersectoral table, the Healthy Communities Partnership. They actually had to move the wall to expand the room. There were so many people who wanted to come, which is a reflection of the housing crisis, but I think also a reflection of the way that we were, through partners and collaboration, really building a sense of community momentum on this. Directly following that high-level briefing, we spent the rest of the day, 50 people who were participants in the research and others, talking about the what's next. How do we move this forward? And spontaneously on the spot, some of the participants just sent around a list, and people signed up to form the Rent Safe Owen Sound Collaborative, which 2 years later is still meeting, and not only meeting, but engaging in their own local research, which I'm supporting on the side, to further explore housing conditions from both the perspective of tenants and from landlords. And one of the other things we did is an intersectoral video, Housing Issues We're Here to Help. And this was actually a reflective exercise, in the sense that we prompted all the various agencies, public health, mental health services, legal aid, and so forth, to think, what does your agency look like to somebody who's maybe hesitant to reach out, but is opening the door for that first time? So we sent around a video crew to actually get them to virtually welcome community members into their space and explain how they work and how they seek to provide supports. It turned out really to be good timing as we then moved into the pandemic. So there were some online resources that helped to break down some of those barriers to tenants reaching out. So we are in the process of sort of distilling this and really motivated by how can we use this research in a practical sense? How can it help public health and others find ways to work intersectorally in ways that move upstream and start to challenge some of those contextual structural issues? So we've written one paper that's out, that's looking at the different buckets that you can place some of the discourse and the learning. So One bucket obviously being structures, the lack of housing, the bricks and mortar, the waiting lists, all of those sorts of things, the funding, but equally importantly, the knowledge, the perception and perceptions and beliefs. So not just in the professional sectors, the service providers, but in the community at large. So things like racism, things like attitudes that people who are on low income somehow must be getting what they deserve and don't really deserve a decent, healthy place to live. And then the third bucket being practices. So even in the context of the research, even within a 90-minute learning exchange, you would see the light bulbs start to go off of, a public health practitioner talking about handing a phone number to somebody in mental distress, and the tenant co-researchers gently pointing out like that person's probably not going to be able to use a phone number or a brochure. So how do we bring those wraparound supports and actually meet people where they're at, and challenging some of that tunnel vision and bureaucratic rigor that tends to exclude people from the day-to-day practice in the various agencies. The other lens that we're looking at the research and still working on getting this out there for people to use is to think about the process, how these bringing together and focusing on relationships can help to re-problematize. I think too often we think we know the problem that we're working in, and we don't critically examine that. So housing, well, it must be we just need more housing. Well, of course, that's not the case. It's the determinants of health, it's poverty, it's racism, and so forth. So defining what the problem actually is needs time and needs discussion. Reflexivity, really getting service providers. This is again that reversing the gaze to look at, well, what are the gaps in the system itself? What are some of the practices that can exclude people from accessing services? And then the third bucket is really thinking about individual as professionals, our individual and collective agency to be part of the shift that we're trying to see to start to address some of those upstream factors. So, marshaling the courage to push back against things that seem unfair within organizations, building those relationships, and developing a collegial relationship rather than a consultative relationship with people who have grounded expertise. So in a nutshell, equity-focused intersectoral practice, or EQUIP, means really asking those upstream why questions, building intersectoral knowledge practices that invest in human relationships, create non-hierarchical safe spaces for people to truly share their views and perspectives, fostering knowledge co-creation, and prioritizing grounded expertise as that really critical lens for helping to examine and elucidate those gaps in the system, those gaps in the policies and practices. So traditionally in knowledge translation, we think about dissemination of information out to the community. In this project, we were kind of doing the reverse. We were asking the community to help us critique the system itself and to think about the knowledge flows and the knowledge power dynamics that exist therein. So concluding thoughts, I always like to think about what are the opportunities today or tomorrow for those of us working in public health and health related fields or other sectors as well. And I think for me, the primary takeaway is just the incredible power and richness that comes from centering people with grounded expertise. Their wisdom can really help shift conversations and shift the focus, those solution pathways. Constituting intersectoral ways in ways that can contribute to reconciliation. We made efforts to do that. And I will also note, don't have the time to explain it in detail here, but the Giwe table, also in Owen Sound, led by the Indigenous Friendship Center that kind of grew out of common roots with the Rent Safe Equip work, is a really excellent example of an Indigenous-led intersectoral housing approach. So check that out if you get a chance. Another possibility for public health practitioners is to just try out some of the things that we experimented with, convening a learning exchange, having it co-convened with people with lived experience, and see what you can learn from that. Undertaking what I refer to as a reflexive intersectoral project. What happens when we literally shine the video camera at ourselves, and how do we explain who we are and what the services are that we provide? Leveraging research as my doctoral work was sort of a mid-career undertaking, and I've really come to appreciate the ways in which having a research space can help to take away any turf issues and create sort of an open space where intersectoral actors can come together. So really thinking about strategic partnerships between public health and researchers and using those to the benefit of community work. And then finally, really embracing the really important role that public health can play as a convener of intersectoral work. So that's, I thank you for your time. I'm very happy to answer any questions now or later on by email. And I do want to acknowledge the many people I had the good fortune to work with over the course of the work. Thank you.
Wonderful, Erica. This was fantastic. For anybody with questions for Erica, please, you can type those into the Q&A box anytime. We'll make sure that we address those when we get to the Q&A section of this webinar. And not to hold things up, I will pass things on to Dr. Sujane Kandasamy.
Thank you so much, Emily. Can you see the slides okay?
Yep, looks great.
Okay, excellent, thank you. I wanted to take a moment before I begin to recognize the land acknowledgement that was made at the beginning of the webinar. I too am grateful to live, work, and play on the traditional territories of the Haudenosaunee and Anishinaabe peoples. And as a guest and visitor, I continue to take responsibility to respect and honor the intimate relationship Indigenous peoples have to this land. So thank you very much for the opportunity to present to you this presentation that weaves together some of my dissertation work that I had the good fortune of completing at McMaster University in the Health Research Methodology program. So some of the key topics I wanted to cover in this presentation were first to set the stage with a brief introduction, to do a little bit of a deep dive in terms of the key concepts, to highlight some of the key lessons through the learnings from this project, and then to touch a little bit on future directions and next steps. And I wanted to weave together all of these pieces using, by sharing with you actually a short documentary style film that I had the pleasure of creating in partnership with a few other artists, local artists from the community, including a filmmaker and illustrator. But first, I wanted to draw your attention to a concept that I think relates very closely to equity and knowledge translation. And that is this idea that strategies, programs, KT interventions must work in tandem with the community of interests culture, whether it's linguistics, worldviews, underlying beliefs and histories, environment, or space, in order for that to be appetizing and increase uptake. And alternatively, if effort is not invested in tying and interweaving the strategy and the cultures together, as Peter Drucker famously said, culture does eat strategy for breakfast. So without further ado, I wanted to share this documentary style film with you that brings together these concepts and really highlights my thoughts and insights and work throughout this dissertation. Every research study is a journey for the researcher, a journey for the participants, a journey where clarity is defined, data is collected, organized, and presented, where ideas are rearranged, thoughts are pieced together, and a story is told. An end product is revealed, a contribution is made to the depth and breadth of a field of study, a gift is given,
left behind for someone else to build upon. But how you package that gift and how you choose to reveal your story may not only be parceled with elements of surprise, but can also lead to community building, engagement, increased uptake, and response. The telling of these stories is what connects us together, what helps us grow, what helps us thrive, what fills our souls and feeds our minds. We are ultimately nested in stories. This story is a little different. It's actually 3 stories nested into one big story. And because of this, what was hard for me to decide was whether I should start from the beginning or work backwards from the end. I also considered letting it unfold organically, but a fear of that was whether all my thoughts, convictions, and hopes would be thoughtfully shared. But one thing I know for sure is that this research story you're about to hear is one that has been brewing for many years. And although it composes my entire PhD dissertation, it is only a small contribution to the field that has been plowed, nurtured, and grown by the researchers, epidemiologists, public health professionals, and scientists who have come before me. My journey begins as a speckle in that field, with the hopes of smashing the barriers between research and practice, between academia and community, between science and the arts. And in the place of that barrier, to build bridges, passageways filled with lessons learned and challenges overcome, so that others may take even a small nugget from this work and build it into their own. That speckle of inspiration that fueled me came many years ago from my master's research. From this project, I had the privilege of working with the Six Nations community to better understand perinatal health beliefs, and recognizing the critical role of co-design, joint data analysis, and culturally tailored communication changed my perspectives of what it meant to be a researcher. And to understand that for all of this to unfold would be hard work, but also good work, well, that part probably changed my life. I reflected a lot on this, and it began to take me into the direction of knowledge translation. What does that mean to me? Well, I consider it like this. Good quality knowledge is a lot like refreshing lemonade. Often stemming from a challenge, the research team makes it, the manuscript bottles it, the peer review tastes it, the journal sticks a label on it, and archive systems store it in a grocery store fridge for it to be purchased. But what if it's too expensive to buy, or shoppers don't know where to find it, or it's time-consuming for people to research the best brand? Now enter knowledge translation, the process of opening the bottle and serving it. It is a very intentional, interdisciplinary effort. I wanted to study this process more. I wanted to learn how it could be evaluated, improved, and scaled. I wanted to understand how I could make it more interdisciplinary. I wanted to learn how I could use multimedia and more engaging digital tools to translate evidence to different communities. While I was dreaming up ways that I could achieve this, I was simultaneously introduced to an emerging public health challenge in my own community. Being a South Asian woman, I have witnessed the impact that cardiovascular disease has had within South Asian communities. I have seen the ambiguities within my own family, and now, learning that gestational diabetes, GDM, was on the rise in Southern Ontario was truly devastating. GDM is high blood sugar during pregnancy among women without previous diabetes, and is also considered a condition that increases one's prospect of developing type 2 diabetes. This rising prevalence was the lemon. A public health challenge was before us. A priority population was being impacted, and something had to be done. Nesting dolls are associated with family and fertility. They are representations of the mother-child relationship, often seen as mothers carrying on the family legacy through their child in their womb. Metaphorically, nesting dolls are associated with a design paradigm known as the matryoshka principle. It denotes an identifiable relationship of objects within similar objects. And it all begins with the baby, the evidence, the most crucial doll, the first story. High-quality public health evidence from the South Asian birth cohort study was demonstrating that 36% of South Asian women would develop gestational diabetes, compared to a rate of 5 to 15% in the general population. This was a problem. From this birth cohort of over 1,000 mothers and babies from the Peel region in southern Ontario, we also learned more about risk factors in addition to family history and the importance of a high-quality diet during pregnancy. We paired this evidence with other systematic reviews on perspectives of gestational weight gain, knowledge translation tools designed for this population, and a local needs assessment to better understand barriers and facilitators of lifestyle change among pregnant South Asian women and their prenatal clinicians. From this, we recognized that there was a need for culturally tailored resources that could address knowledge gaps, could address time-related barriers, and could address logistical challenges in early prenatal care. Taking this knowledge and nesting it within a tool, a set of resources that could help unlock that evidence. To do this, I worked with a graphic designer to create a tri-part multimedia toolkit for pregnant South Asians and their family doctors. This tool is represented by the second doll, the second story. The patient-facing version of this tool consists of 1, a video narrative that contextualizes the challenge around high GDM prevalence among South Asian women. 2, a pocket-sized guidebook with personalized elements and suggested questions to inquire about at future clinic appointments. And 3, summary reminder material in the form of a compact fridge magnet. The family physician-facing version of this tool consists of 1, a resource kit, and 2, a laminated summary card with evidence-based information, suggested scripts, and links to supplementary resources. To create this toolkit, we aligned our process with theories and frameworks, and also injected components of arts-based considerations. We thoughtfully considered what types of illustrations, colors, images, text, paper, sizing, video and filming techniques, and narrative approaches that we would use. With the evidence nested in the tool was then nested within an evaluation. This evaluation was conducted in partnership with 2 local family practices in the Peel region. We wanted to understand the feasibility, interest, and acceptability for this tool, but also to explore if it could be used to improve knowledge, attitudes, practices, and confidence. We found that this topic had a high degree of interest, feasible recruitment, and good retention. Pregnant patients valued the new information they learned, changed some of their diet and physical activity practices, and also made recommendations to improve the content and layout of the toolkit. We then nested the results from this evaluation into a final, community-facing production, a production that weaves together 2 artistic pieces. First, a digital illustration, and second, a short film. This is the 4th doll, the 4th story. I partnered with a South Asian illustrator and artist to take the findings from the evaluation study to create a visual representation that can be used to foster conversations among communities of interest, to build bridges between research and community, and science and the arts. The 2 of us had a long email thread and 1 detailed video conference to co-create a plan for how we could do this. We prioritized the key results within the concept that lifestyle counseling about GDM is a ceremony between physicians and patients, where it is vital to meet pregnant women where they are and build the advice on top of that. We discussed building the piece on the literal and figurative stethoscope that lies between them, the headpiece which symbolizes the physician's perspectives, the chest piece that symbolizes the patient's perspectives, and the connecting cord, which symbolizes shared views and expectations. At the headpiece, we see the use of different South Asian languages to better connect, the use of open-ended questions, and the understanding of personal, familial, and cultural influences. At the chest piece, we see the pregnant women's perspectives around dietary preferences, South Asian traditional foods, influence of elder women, and the challenges of cravings, monitoring glucose, and controlling pregnancy weight gain. The connecting cord is adorned with gold bangles, a traditional representation that goes back to ancient civilizations and symbolizes more than just ornamentation. It represents cultural norms, practices, and rituals as they relate to the auspiciousness of unities and the role of fertility, pregnancy, and child rearing. In the illustration, the cord begins with thin bangles, and as we go closer to the chest piece, they become thicker and more prominent. This symbolizes the building and strengthening of trust between pregnant patients and their family physicians. Building from this illustration to create this short film is also a process that involved reflection and interdisciplinary partnerships. It included writing, editing, and finalizing a script, audio recording the script, planning a storyboard, filming, editing, refilming, re-editing, but the most important part was finding the story and using visuals to enhance the words of the story. It is looking for the thread that weaves together all of the individual components in a meaningful way. In some cases, it may be a metaphor, a personal narrative, or the interweaving of both. Either way, it reiterates the idea that every study is a journey, a story. It can be told, built upon, and retold. The telling of these stories is what connects us together, what helps us grow, what helps us thrive, what fills our souls and feeds our minds. We are ultimately nested in stories.
Thank you so much for walking on that journey with me and for allowing me to share that short film. I just had one last slide just to bring all of the pieces together and to reiterate some of the components of the nesting doll principle that was used throughout the film. So you saw, the evidence being built into the tool, being built into the evaluation, and then being built into the community-facing knowledge mobilization efforts. And throughout that process, were integrated pieces of co-design, joint data analysis and mobilization, as well as plans to iterate, innovate, and scale this project to the next level, which in this case includes making the iterations based on feedback from our patient partner and our evaluation study, and to build a version 2 of this toolkit for both patients and their prenatal clinicians. Thank you very much, and I will leave it there. Back to you, Emily.
Thank you so much, Sujane. That was a beautiful presentation. Really, really wonderful that you shared that with us. If you have any questions for Sujane, please type those into the question and answer box. And now we will move it over to Dr. Lee McLarty.
Thanks so much. I'll just get myself set up here. And hopefully that looks okay. I just need to move this so I can see my notes. Okay, so good afternoon, everyone. Thanks so much for joining. And thanks to my co-presenters. Those were both really incredible. And I'm just feeling lots of feelings that I need to sit with after this. That was just really wonderful. Thanks for that. We'll shift gears a little bit and I'll present some components of my PhD dissertation, which I called Critical Exploration into Manitoba's HIV Care Cascade. And at the end, I'll specifically talk about how equity-focused data visualization can be used to support knowledge translation. Before I begin, I do want to recognize that I'm presenting today from Treaty 1 territory in Winnipeg. All of my PhD work was conducted on Treaty 1, and the Manitoba HIV program, with whom I worked extensively throughout my PhD, has clinic sites on Treaty 1 and Treaty 2 territories. And these are the original territories of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and it's the homeland of the Métis Nation. And all of these people have called this land home for a time long preceding the arrival of settlers like me, and I just want to acknowledge that. So I just briefly about myself, I guess I'm currently a postdoctoral fellow at the Institute for Global Public Health at the University of Manitoba, and I completed my PhD in community health sciences also at the U of M at the end of last year. So I'll just start by providing a little bit of background and context for this work. First, despite evidence of unique HIV epidemiology in the Canadian prairies compared to the rest of Canada, and relatively high rates of new HIV infections annually, there's very little literature focusing on HIV in the prairies, and there's a specific lack of information around HIV in Manitoba. And currently, data describing the epidemiological trends of HIV and the delivery and utilization of relevant services in Manitoba is quite scarce. And this has limited our understanding locally of engagement in HIV care in the province. So one of the main goals throughout my PhD was to generate evidence that would contribute to a hopefully growing body of information that can be used to inform programs and policies around HIV care in the province. And this all started to become possible in 2013 when CIHR funded a multi-site program of research called the LIVE study, which was led by Dr. Claire Kendall at the Vanier Research Institute in Ottawa. And it was through the LIVE study that Manitoba received support for establishing a prospective clinical cohort of people living with HIV in the province. And the development of this cohort was really the first objective of my dissertation. And so this was the first comprehensive source of HIV-specific health data for our province, and we published a cohort profile in BMJ Open at the end of 2020. And as the second part of my dissertation, I used that data from the clinical cohort to develop the first and most comprehensive HIV care cascade model for the province. And I did this through an iterative consultation process with key stakeholders across Manitoba. And we also generated local estimates for each step of the HIV care cascade using data from the cohort. And we published about the process of developing the cascade model and generating estimates in the Journal of Clinical Epidemiology, also at the end of last year. So just some citations there if anyone's interested in reading more about the details behind that. So I used a few different frameworks or theoretical orientations for my work. The first is program science, and this is really a framework that's focused on optimizing the performance of public health programs through an iterative process that involves scientific inquiry embedded within the context of a public health program. And program science is inherently equity focused. It aims to maximize the population level impact of a public health program through the prioritization of populations and geographies that would benefit most from targeted program activities. My PhD work is also an example of an integrated knowledge translation project. So I was actively partnering with stakeholders across Manitoba throughout my PhD, specifically the Manitoba HIV program and other community clinics. Manitoba Health, so our Ministry of Health within the province, the Manitoba First Nations AIDS Working Group, as well as a community scholar program, which was funded through the LIVE project. And working with all of these stakeholders and partners was really important for me to not only develop the specific objectives for my dissertation, but also to make sure that the objectives were aligning with priorities of the Manitoba HIV program as the primary care provider in our province, but also other stakeholders and community members in Manitoba. So the other framework that I wanted to just briefly touch on is the HIV care cascade. So this is obviously central to the work that I did, and just in case folks aren't familiar with it, I'll just go briefly over what it is and how it's used typically. So the cascade's a framework that follows individual level progression through a continuum of HIV care services and related treatment outcomes. Typically, their cascades are depicted using depict the proportion of individuals in a population of people living with HIV who've been diagnosed and then linked to HIV care services and retained in those care services, then initiated and sustained on HIV treatment to ultimately reach virologic suppression, or basically putting the virus to sleep. So the figure here on the left is just showing one of the first conceptualizations of the care cascade, which was developed by Gardner and colleagues about a decade ago now, which makes me feel old. But there's been lots of great work since then. So I suppose that's one thing to be happy about. The cascade can also be used as a tool to monitor overall performance of HIV care programs, and more broadly to assess performance of health systems with respect to the provision of HIV treatment and care at a population level. And then more recently, simplified versions of the cascade, such as the 90-90-90 initiative, have been used to track countries' progress towards meeting high-level public health targets that are set by policy normative bodies like UNAIDS and the WHO, for instance. And until recently, or until I finished my PhD, I guess, a comprehensive HIV care cascade model hadn't been developed in Manitoba, though it's important to note that many jurisdictions in Canada and across the world had been developing and updating cascades for many years already. So briefly, this is the final cascade model that was developed through my PhD work. And I'll just quickly run through. There's 703 participants in this included in the cascade in the first alive and diagnosed step. And then among them, 90.8 were classified as in care, 86.2% were retained in care, 81.5% were on treatment, and then 74.4% were categorized as virologically suppressed. And I mostly wanted to just share this baseline cascade because it's really the model upon which I conducted subsequent equity analyses, which I'm going to be talking about momentarily here. So the reason we wanted to do equity analyses on our cascades, or why we thought it was important, is because as we all know, the Sustainable Development Goals really have equity as a central and cross-cutting theme throughout their targets, and the idea of leaving no one behind is really emphasized as well. So just in general, there's an imperative for public health researchers to be focusing on health equity, and this isn't always done very well with the cascade, although as I was working on my PhD, I think it became more and more common for folks to be thinking about equity and disparities across the cascade. So conventionally, HIV care cascades have been created using aggregate data that really illustrate engagement and care across an entire population. But this approach really runs the risk of obscuring heterogeneity that exists within a population. So by examining a cascade through an equity lens and using disaggregated data to construct cascades for different population subgroups, that's one strategy we can use for better understanding inequalities that exist across the cascade. And we are beginning to see this a little bit more out of a number of jurisdictions, both in Canada and internationally as well. So the first step of my process for equity analyses was to identify relevant equity variables by which I would ultimately disaggregate the cohort data. And these included a variety of variables on sociodemographic characteristics and reported HIV exposure categories. I then used two analysis methods to examine these disaggregated data through an equity lens. The first were equiplots, and these visualize inequalities between participant subgroups in each step of the care cascade. And equiplots are a relatively new visualization and analysis tool that were originally developed at the International Center for Equity in Health in Brazil. And they're probably best known for being used to demonstrate inequalities in a variety of country level indicators that are measured in the Countdown to 2030 initiative. But today I'm presenting a novel use of equiplots to examine inequalities across the HIV care cascade in Manitoba. And then to complement the equiplots, I run multivariable logistic regression models to quantify the observed inequalities and infer statistical significance. And just to note that these equity analyses have been published in BMC Public Health earlier this year. So I'm going to walk through 2 of the 6 equity analyses that I did in my PhD work, and I'll at the end focus specifically on highlighting how these equiplots can be particularly useful for programming and for knowledge translation. So on the right-hand side of this slide here is an equiplot, and it's illustrating the Manitoban cascade data disaggregated by age. So we have each step of the care cascade represented along the y-axis here, going from top to bottom. And so top is left on the previous cascade that I showed. And along the x-axis, we have the percentage of people in each step as a proportion of the first alive and diagnosed step. And then at the top, of course, we have the different age groups with the different colored markers indicating the different population subgroups. So when we look at the data in the equiplot, we can see a pretty clear and almost linear relationship between age and progression along the cascade. So we see that the relative proportions of participants in each cascade step are increasing with increased age. And in particular, we note this youngest age group with the red marker is substantially underrepresented in every step of the cascade. So then once we visualize these inequalities in the equiplot, we can look to the table on the left here, which is depicting results from a multivariable logistic regression model. And we can then determine whether these inequalities that we visualized are, whether they're of statistical significance when we quantify them in the model. And so according to the table, we can see that the youngest, when compared to the youngest age group, participants who were 40 years and older are significantly more likely to be in every single step of the care cascade. And participants in the 30 to 39 year age group have an almost 2.5 times greater odds of being retained in care compared to the youngest group. But statistically, they're no more likely to be in care, on treatment, or virologically suppressed. So in this case, when we sort of compare findings or interpretations of the data from the equiplot and the model, we can see that we kind of come to similar conclusions. In this next example, where we're looking at the cascade data disaggregated by geography, we can see that participants living in Eastern Manitoba, shown by the purple diamonds, are doing pretty well along the cascade compared to those in other regions. And there's really very little drop off between each cascade step for this group. When we look, on the other hand, at this group from Western Manitoba and the blue triangles, they appear to be less engaged in care in the earlier steps of the cascade, especially on the in-care and retained in-care steps, but are less different from other groups in the later steps of the cascade. And the final point I just wanted to point out here is the one virologically suppressed marker for the Southern Health group. And this is obviously quite a drop from the earlier on treatment step, which was at about 77%. We went down to about 55% of that group. So our regression analyses suggest that the odds of Western Manitoban participants being in care are 1/3 that of Winnipeggers, and Eastern Manitobans are nearly 4 times more likely to reach virologic suppression than Winnipeggers. So I think these geographic analyses really highlight some of the complexities that we need to pay attention to when we're so used to relying on statistical inference to determine whether patterns or trends are significant, and especially when we're thinking about their role in making decisions around programming. And so what I mean is that, for instance, when we can see quite clearly that there's a substantial drop off in the proportion of participants in Southern Manitoba reaching the virologic suppression, this isn't really captured as this is not captured as a statistically significant finding in our multivariable models. So noting these discrepancies in our analyses is important to keep in mind, particularly when we're thinking about programmatic or policy implications of our findings. So I just wanted to finish here. The equiplots in my work are positioned as innovative and critical knowledge translation tools that draw attention to programmatically important inequalities across the cascade, which may be missed if we focus solely on statistical significance in the multivariable models. And there's a growing body of literature that's encouraging public health research to make use of appropriate data visualization techniques to support the uptake of evidence into interventions, programs, and policies. And effective data visualization tools like an equiplot can be really helpful with meaningfully engaging end users in discussions around findings, and they generally enhance the effective translation of data while also enhancing interpretations of their meaning, potential implications, and utility in the context of public health programs and care delivery. And so in this case, visualization and interpretation of cascade data through equiplots may be more programmatically useful than examining logistic regression analyses for identifying points of potential intervention and program adjustment to ensure equitable health outcomes across the population. And when we present data this way using equiplots, the inequalities between groups in each step of the cascade are easier to visualize. And this creates opportunities to begin asking programmatically relevant, hypothesis generating questions based on those identified gaps. And then we can also begin to think about the ways in which program embedded research can help us to identify and develop strategies for addressing these gaps and ultimately optimize programming to reach population level impact. So I'll stop there and just my thank you slide. And thanks again to the co-presenters.
Thank you so much, Lee. That was a fantastic presentation. Really wonderful to see how really easy it is to visualize then the inequities once you have them on these equiplots. That was really, really enlightening. I appreciate that. So now we will be moving into the Q&A portion of this webinar. So we do invite attendees to submit their questions. We invite all panelists to participate in the Q&A. I don't see any questions that have come through yet, so I'm thinking just to get us started, I was wondering if maybe each of you could speak to what was one critical facilitator for success as you were completing your projects or your dissertations. What was it that really helped move things along for you? And I'm happy for you to answer in any order that you like, but something that was really critical for success in your projects.
I can jump in, Emily. It would be hard to narrow it down to one because I felt very fortunate to be working with so many terrific people from the local public health department to the Indigenous Friendship Center, the Poverty Task Force, and the co-researchers et al. I think for me, the thing that really helped make the research meaningful and productive, at least from my perspective, was my background in the nonprofit world. So I had really developed an appreciation for the power of human relationships because I work in a collaborative. I've been working with the Canadian Partnership for 12 years, bringing together different sectors, different partners, different perspectives on shared commitment to children's environmental health protection. And I've always been really impressed by the power of human connection and that sort of intangible momentum you get when you connect human beings with one another. So I felt pretty fortunate to already have that appreciation going into participatory action research, which was something I had never done before. So I felt that was helpful. And I guess on the other end of that, just really grateful for the opportunity to undertake research that's going to lead to something, hopefully, that's of practical value. I really appreciate researchers who are contributing to bodies of knowledge for the sake of knowledge itself. For me, what was motivating, again, coming from that nonprofit sort of advocacy perspective, is what can we learn that's going to change what we do to make lives better for people. So that was a long answer, but I mean, it was really the driver for me, and what really made this this research really integral with who I am, what I want to be doing, and the broader work in which I was already a part of.
Thank you, Erica.
Emily, if I could jump in, great question, and thanks for your insights, Erica. I think for me and my project, I think one of the key facilitators to success was really developing a protocol that was very flexible and kept in mind kind of the different needs that participants might have to engage in this work. And it became particularly evident to me during the pandemic, actually, with a lot of closures and changes in the ways that things could operate, and had that flexibility that dynamic flexibility had not been built in, I think it would have been a lot more challenging to continue the work to completion. Whereas like if you sort of think about, how people might be in different situations and trying to still engage with your research, like in regard to transportation or access related issues, I think building those in early on can be very helpful for the progress of a study.
Yeah, so I think for me, probably it was general, if I can just say broadly, is just partnerships. So as I mentioned sort of early in my presentation, there's really not been a lot of work done on HIV in Manitoba specifically, or looking at the folks living with HIV in the province. And so it was really important for me to be able to have open and engaging partnerships with the Manitoba HIV program. So I was really thankful that folks in the program were open to having a researcher come and hang out with them and sort of try to do a research project in the context of a really hectic environment, a clinic environment. And so that was important, and I couldn't have done it if folks weren't open to that. So the whole management team, the clinical care team, and also just the time that people were willing to take to answer my probably naive questions a lot of the time, and also just to sort of help me navigate a really complicated care system. So yeah, I think that would be sort of the biggest thing that helped my staff move forward.
That's great. Thanks for your thoughtful answers. I really appreciate that. I think for now, I'll ask one more question, and if nothing else comes into the QA, then we'll move on to wrapping up. But just curious, what's next for each of you? I think you've all graduated now. Where are you setting your sights on next? What's next in your careers?
Well, I could start by saying that I always like to allow for the possibility of surprise and serendipity in life trajectories, mine or anyone else. So I won't predict too far into the future, but I guess maybe one of the things that I'm finding really rewarding is having a continued relationship with the Owen Sound community. So since the project concluded, my PhD was finished and our grant was finished, I've joined a team led by the University of Montreal, which is also looking at intersectoral tables and how they respond in the circumstances of change in the context. So right now I'm doing qualitative research, again, having a chance to go back and check in with people about the rent safe work, about GIWE, about the Housing Action Group of the Poverty Task Force, and how such tables either mobilize or stall out or change in other ways in response to changes in the contextual environment. So COVID obviously being really transformational, and we're early on, but I think that there's going to be really interesting learnings coming out of that, because we can see the pandemic causing some things to grind to a halt. But when we talk about local work to address a social justice concern, a health equity, a housing crisis, and other sorts of really pressing needs, I think we saw the opposite. I think we saw people tapping into those human relationships, getting to, yes, we need this now, let's fix this problem, there's a need here. And within hours, these people were able to build the supports needed to address, housing, a rooming house that was under lockdown, and the very complex needs of the people inside and so forth. So I think it's going to be teaching us some of the value of that those intersectoral connections, which make you quite nimble in the face of an urgent crisis, and hopefully also make you nimble and adept at addressing the long-term structural changes, which of course is always the elephant in the room when it comes to housing. So anyway, I feel fortunate to be able to remain engaged and hopefully continue to contribute to what's happening locally. And also, of course, we do this work as well as researchers to be able to see what's, what learnings can help other communities address similar work, whether it's housing or food insecurity or any other type of enduring challenge.
Wonderful, thank you.
Thanks, Emily, for that question. And once again, Erica, for the response. I think for me, I'm trying to keep a lot of options open. Currently working on a Healthy Communities, Healthy Canadians grant, looking at co-designing a nature-based intervention in a community in Hamilton. And alongside that, really looking for new ways to cultivate, kind of bringing in film and other arts-based efforts into public health initiatives and telling stories in new and creative ways and sharing and exchanging knowledge with communities of interest in through telling stories and through digital media. And that's always been a real passion of mine, and really been a journey that I've been on to really integrate and weave together those aspects and kind of being at the intersect of being able to do that and to facilitate those conversations, because I've been fortunate enough to have experiences on both sides of that path, that I find it really rewarding to be in the middle and kind of be a liaison between those two fields.
Great. Thanks. It's actually really interesting for me to hear what other folks are doing after their PhD. Some people have really, really clear ideas of where they're going, and others, like me, have less clarity. But right now I'm working, so I'm really interested in trying to focus a little bit more on bridging a gap that I think lots of people have acknowledged, but specifically at the Institute for Global Public Health, we've been working on is sort of bridging a gap between programs and science, and how to integrate research and learning into public health programs. So most of the work that I'm sort of focusing on right now is convening some thought leaders and folks on ways that we may need to change our programming ecosystems and our science or research ecosystems to bring them together in a little bit of a more seamless way to make sure that research is informing programming in a way that makes sense for programs, and that research on programs is also being informed by programmatically relevant questions to ultimately enhance and optimize programming and the impact of the programming at a population level. So that's sort of very broadly what I'm working on now.
That's great. It always feels like almost a mean question about asking what's next when it's when we haven't decided yet. But that's great. Glad to hear. I'm sure you'll all be moving on to great things. At this point, what we're going to do is move into a little bit of the webinar wrap up. If any more questions come up, we can probably address those. So a couple of things from the NCCMT. We are looking for stories of using EIDM in your practice. That's evidence-informed decision-making. And if you need support for evidence-informed decision-making, you can email us, nccmt@mcmaster.ca. We usually get back to you within 24 business hours. I know that I often answer these, and it's a nice break from my typical work routine, getting these questions and engaging with the community. So please don't hesitate to get in touch. We do have a very brief poll for some webinar feedback. We're interested in whether or not the webinar was effective in increasing your knowledge and understanding of evidence-informed decision-making, whether the information from today's webinar will be useful in your practice. and some questions about the execution of the webinar. And again, we thank you so much for participating. We do review this information quite closely. Twice a year, we'll roll up all the responses that we get, and we certainly do modify our approaches and choose topics and that type of thing based on the responses that we get. So we really do appreciate any audience feedback that we do get. I see responses are coming in, which is fabulous. Really appreciate that. Make sure that you hit submit once you have entered your questions. And I think we've got just about everybody. So that's wonderful. Thank you so much. And then in terms of webinars from the NCCMT, I don't think we have any planned until the new year at this point, but you can keep an eye on our webinars page. You can also sign up for our newsletter on our website, nccmt.ca. Keep an eye on our Twitter and Facebook feeds, and we'll always include any upcoming webinars there as well. And I will leave it at that. For any more information about the NCCMT, about the KT Student Awards, including how to apply for the 2022 awards, feel free to reach out to us at nccmt@mcmaster.ca. I want to take this time to thank our panelists for their really fabulous presentations, really engaging and well presented, and just such amazing projects. We're so glad to be able to share that with the audience today, and certainly wishing you all the very best in whatever it is that comes next, whether you know what that is yet or not. So huge thanks. Really appreciate this, and really enjoyed being able to present this today.
Thank you, Emily. Thanks for the opportunity to participate.
Thanks very much.
Thank you.
Thanks. Take care, everyone.